this is a lifespan perspective, but I want to just make sure that we keep in mind that we are, in fact, in a demographic revolution. The population structure will never return to the population pyramid I was trained on with more youth and few elders. It's now a very much rectangularized structure, and it will never go back. We have been through this revolution now. We have to live with it, and we have to figure out what that means for us. So the second point I want to make, because I am a professor, and I know I have 5 minutes. I normally teach 2 hours, but that's okay. Is that I want to make sure people really know that the prevalence rates for mental disorders in older adults are really quite similar to that in young adults. About 20-22% of the population. It doesn't really matter what age group you look at. So it's not like with age we become wise and mental health issues go away. That is not true. The mix of the mental health issues begins to shift a bit. So actually, older adults have a slightly lower prevalence in anxiety and depression, and it's truly a slightly lower level. But we have the addition then of the cognitive impairments in which over the age of 85, people living in the community, about 1/3 of them, 1/3 living in the community, not in facilities, are dealing with serious cognitive impairment that has functional impact. We need to start getting our heads around that and what that means. So when we think about these older adults, there's been a lot of a long-term myth that's been really hard to kill, that older adults don't want mental health services or they won't access them. And the data are clear that that is not true. Again, I entered the field essentially 40 years ago, and at that time there was a lot of stigma among the older population about mental health services. Today, you cannot find data that show that older adults have more stigma against receiving services than young adults. So don't let ourselves off the hook by saying they don't want it. The issue is not that they don't want it, the issue is access. Let's be really clear. It's access. So what are the access issues? The access issues, number 1, are provider availability on an outpatient basis. Getting access to people who will receive Medicare, people who are trained to work with older adults, and all the complexities in the stories that you just heard is a serious problem. Our reimbursement rates are not as high in Medicare as in many other provider payer sources, although they're better than many managed care payer sources. So we need to be careful that we give the message that this is a viable career path, that you can make a living at it. And having said that, the expansion of Medicare Advantage programs has thrown healthcare into chaos. So at this point, a healthcare provider needs to be impaneled on 40 or 50 different panels, and that's not feasible, and it's the back-end business side of that is a hot mess. So what's given to consumers as a simple message, come in, you won't have copays, you'll get all these other services, on the back end can end up being a problem because they can't find people on their panels that provide geriatric services, which is, of course, ironic in a Medicare Advantage program. But it's true. It is definitely true. In the inpatient world, we have a huge problem, and just Lisa's description of the woman that she worked with on the streets who needs mental health services, oh my goodness, the difficulty we have around inpatient services for people who have serious medical issues and psychiatric issues and social issues. Those are the folks that we're serving very poorly. A traditional psychiatric inpatient unit does not meet the need. We overwhelm them with medical need, or we put people in a hospital, an acute care hospital, whose behavioral health issues cannot be managed. The capitated payments for Medicaid that come from the state to a region exclude so many diagnostic categories that it's very difficult to set up a treatment program. If you're only allowed to treat depression, serious mental illness, anxiety, and you're working with older adults where cognitive impairment is present, but your providers can't bill for that under the capitated system, we've got a problem. And I want to certainly also note that access, another big access issue, is that older adults rely on and want their families involved in their care, and we know that families provide 85 to 90% of all of the long-term care in this country. 85 to 90%. If you add the fiscal value of that, it turns out to be more than the federal Medicaid budget. We cannot offset from families to all providers. The elders don't want it, the families don't want it, and we couldn't afford it. So what we need to do is to create some very innovative ways of engaging families in our service provider structure. And we tend to have tremendous anxiety about HIPAA issues. And what that means is that we get all focused on the individual as if they're not embedded. So I have to say my last point, because I'm a professor, that's geriatric workforce. I don't care which healthcare profession you're talking about, we are not developing a workforce adequate to meet the need. Psychiatry, psychology, social work, counseling. We just aren't, we don't have the pipeline. We can address this very directly with loan forgiveness programs where there's a payback agreement. This is not a no-brainer, it's not unfixable. We can fix it by supporting programs that are actually innovating and doing this work. I've run one for 20 years. It's possible to do. There are students out there that want it. We need to give it to them.